Okay, hi Aaron. Thank you very much for agreeing to speak to me. That's fantastic. We're going to talk about simulation. I should say that you and I have known each other for a long time, and we've worked together over many years on quite a few simulations now. Um, but could you give us a rundown of your background?
Um, Thanks, David. Well, I'm an associate professor at the University of Hertfordshire, and I specialize in an area called healthcare modeling, which brings together various subject areas such as operational research, statistics, lots of health economics modeling, analytics, all of these areas into to solving issues within healthcare. So this could be either demand and capacity modeling of a hospital, trying to capture individual patient pathways, where you can potentially examine the impact of changing certain aspects of the pathway and interventions. Could also include lots and lots of big data analytics, the hospital episode statistics data, and other local data sets. They tend to be very, very large. So this would involve developing statistical models to capture hidden patterns and trends, and so on and so forth. So it's an area that brings 4 or 5 distinct fields in order to solve problems within the NHS and pharmaceuticals as well. So that's kind of
Okay,
a short spell about me.
brilliant. Thank you. And today, we're talking in particular about one of those areas. It's simulation and discrete event simulation. Um, I know you and I have done a lot of them together, but can you describe for me what discrete event simulation is and why we use it when we're sort of problem solving or helping organizations make decisions?
Well, we live in a very, very complex world, and sometimes mathematics has its limits. Because with mathematics, it's purely you're looking at the analytical solution. So you've got a simple equation that you can solve. But when it's very, very complicated, mathematics has its limits. So we then have to use some other methods. And discrete event simulation enables us to capture the all the levels of details within a complex field. So, for instance, a pathway, for instance, can be very, very complex from the time of admission until discharge. There's huge amounts of activities that goes on within inpatients, outpatients, A&E, in the community. So what simulation enables us to do is to capture that all of the levels of detail within a system. We can then power that within a simulation environment. So we've managed to capture all of that huge amounts of data um, um, embedded into the system. And the beauty is, once you capture that level of detail within a very messy world, it enables us to test the system. So before you go ahead and implement an intervention, a new design, a completely a new redesign of the system, it enables us to test what if questions when designing this. So we can run all sorts of scenarios. So what if there is a surge in demand? What if we added a new piece of equipment into the system? What if there's a new medication, a new drug in the market? What impact does that have on all sorts of key metrics, whether if it's utilization of resources, whether if it's on the activity, whether if it's cost effectiveness analysis, and so on. So there's no limit as to what you once you capture that reality and power it within a discrete event simulation system.
Okay. Um, and I should add, one of the bits I particularly like about simulation is the ability to um, simulate the impact of restriction in resource. And so, for example, if we only have 3 doctors in a system, then there's only a limited amount of work you do, and it doesn't matter how much you change any other part of the system. That constriction will be there and block, and it's that sort of aspect of simulation I think is really helpful as well in this sort of decision making process. Does this, if so, if we did add another doctor, would it make any difference, or is it more important to add more recovery beds? There's those sorts of questions.
Oh, absolutely, absolutely. I mean, the spectrum of changes and interventions that you can potentially run endless in a simulation environment. There's no way you can do any of this with mathematics or statistics, and that, I think that's the beauty of simulation.
Okay, so let's get a bit practical. Obviously, I've said it several times, we've done a few, but let's talk about your latest project in the Royal Free. Um, Tell us a bit about that project, how it came about.
Well, this kind of started back in 2015 with a PhD student of mine. We've kind of noticed that one of the major chronic diseases and one of the most costly chronic conditions is the chronic obstructive pulmonary disease. I think it accounts almost for about £2 billion a year of expenditure, and it's known to be the second most common cause of emergency admissions. That's after influenza and pneumonia. And so because of the amount of volume and activity, we thought, well, can we do something around COPD, or modeling patient pathways within a COPD service, and test new interventions. So the idea is, if we can capture this reality for COPD, because with COPD there's huge amounts of activity, not just in hospital but also out in the community. So there's a lot of activity going on in the community, so you can imagine how complex this system is. And so that's how it kind of all started, and we've been working on it for almost years, and we've just managed to kind of finish the health economics modeling aspect of it with some really interesting set of results, actually, in terms of identifying the most effective and cost-effective interventions that we could potentially recommend to COPD services in England. So that's we've worked with a very large team actually for this. So we've got a professor in respiratory medicine, as Professor John Hurst from Royal Free Hospital, a team made up of consultants, a physiotherapist, service manager, a number of nurses, the Camden community services. So we've had the community service lead helping us with the community services part, which I believe this is the only model that exists which has managed to model community services for a particular disease at a very granular detail. I think that's what's the comprehensive part of this simulation model is.
Brilliant. I suppose one of the things that rang in my ears there is that you've been working on this simulation quite a while. It's important to say that so the amount of time we spend working on simulations depends on the level of complexity we want to introduce into the simulation. Is that correct?
Absolutely, absolutely. I mean, one of the reasons why this took a very long time, it's a PhD study.
Okay, yeah.
One of the requirements of PhD studies, you need to go as detailed as possible.
Yeah.
So it's not the width, but it's depth that matters.
Yes. Okay. So, so in practical terms, if we were to do that without the PhD student, how long do you think it would take us to develop a simulation of our hospital service?
Oh, this could potentially be done within a 3-month period, 4 months max. I mean, it's possible, as long as you're working with the right because this is a teamwork. A simulation cannot be developed by simply a simulation modeler, because there's a huge conceptualization part where you would have to capture this individual footsteps of patients within a service. So it's made up of consultants and service manager, nurses, and so on and so forth.
Actually, that's my favorite bit of it all. But yes, so that's brilliant. Thank you for that. So we've sort of described the project and how it came about. What were the objectives of the project? What was the
well, the core objectives is the community service is now in the agenda, and there is an aspiration within the Department of Health and the government to make a kind of increased use of community services. And the objectives was to model COPD service in hospital, but that's just half the picture. And we wanted to incorporate this community services aspect of it. What are the impacts of increased use of community services into the service? So you can have a look at the utilization of services, You can also study what impact it has on hospital admissions. Would we see any reduction in hospital admissions? Would there be any improvements in patient outcomes? Would there be fewer deaths as a result of increased use of community services and so on? So that's how it all started. And there are obviously other interventions of interest here, for instance, as increased use of post-exacerbation pulmonary rehabilitation. So there's evidence that it's impactful, so it does benefit the patient, but we wanted to kind of examine and evaluate the impact that it has in the hospital services and also out in the community. So there are several interventions that we wanted to. The literature has quite a bit of an information, but nothing at this scale. So because simulation is so generic, we can examine not just the impact on the patient, but the impact on the system. And the system has so many key metrics one could examine.
Okay.
The activity, the utilization of resources, and so on.
Yeah. Okay. And I sort of I'm thinking about that, but basically what we're saying is that it's possible. It's almost infinite what we could test once we have the simulation running. And here you were looking at various bits of about 2 or 3 parts of the pathway that you thought would have an impact. Okay. Next question. How did the hospital interact with the process of developing this the simulation and the process of developing it? And I'm especially interested in how you interacted with people and what sort of relationship you developed with the people in the service.
Oh, it's lovely actually. We've had God knows how many round the table meetings. The first part is the conceptualization, the flow diagram. So we had to sit round the table with all the experts. I think there was about 8 or 9 of us in total, trying to capture every nitty-gritty detail within inpatient services, outpatients, A&E, from all the way from admission to discharge, and then into the community services. Lots of meetings. So we would draw the flow changes within each meeting. And there's lots of meetings around data, because without data, any model is garbage in, garbage out. And so there were many meetings around collection of data within the hospital and in the community services. And it's the community services aspect that was the most difficult part, where we had to have so many interactions because data isn't available. So what do you do then? Right individuals at the right time in order to collect those data. So there was huge amounts of interactions all the way from the conceptualization part until development, because once you develop the model, you then have to go back and verify and validate your findings. Again, you need to have several round the tables. So the next part was the interventions. So you develop the model, so you've conceptualized it, developed it, and then what interventions are we going to be studying? So you can potentially test a number of scenarios just around community services. Is it 1% increase used, 5%, 10%, 15%? The same thing applies for pulmonary rehabilitation and so on. So
brilliant, that's useful. So and basically what we're saying is you became part of the team over this period of development. We've talked about it a bit, but specifically say again, Eren, how was the simulation then used? Once you developed it and you tested, what aspects of the service did you test it on?
So there's 3 aspects of it that we tested on, and we've just got the results for the community services this morning actually. So it's very timely. And the first part was the increased use of pulmonary rehabilitation. Now there's evidence, the post-exacerbation pulmonary rehabilitation. So a patient within 2 weeks of being discharged, they are referred to a pulmonary rehabilitation over a 2-week period, where it's some sort of an exercise regime where patients are educated, which are found to be there's evidence indicating that it may reduce patient readmissions and hospital admissions. So we then had to test this aspect of it. So what happens if we increase it by 10% of patients referred to pulmonary rehabilitation? What happens 20%, 40%, and so on?
Can you describe? I'm just thinking about it. So literally, tell me if I'm wrong, you have a variable within the simulation software, and in this case it might be pulmonary rehabilitation percentage of patients receiving it, and you then literally change the number in that box, and you then rerun the simulation and look at the impact that has had on all the other variables of having run a baseline simulation. Is that right?
Yes, you're comparing. Thanks for that, David. You're comparing the existing service, the current service, with an intervention. So it could be 10% increase, 20% increase. And what impact does that have on the overall model, on key metrics of interest? So this could be number of 90-day readmissions. Is there a reduction as a result of increased use of pulmonary rehabilitation? Total revenue for hospital, number of occupied bed days could be another key metric of interest. Um, some sort of reduction in readmissions and so on. So we're comparing the baseline against a number of interventions. So it could be 10% increase, 20% increase, 30% increase, and so on.
And from my perspective, what's important about the baseline is that we validated it against data. So if our simulation is running and we're predicting this many patients over the next 12 months, we will validate that against the previous 12 months data to make sure that we're within acceptable parameters, and so we know the model is running smoothly. Is that correct?
Absolutely, absolutely,
Yeah.
absolutely. So we're simply testing against those metrics. Yes, I
Okay.
mean there's also the part that I loved about this model is we've got a lot of health economics going on, which we've managed to embed within a simulation environment. Now this is something fairly new, so we can test, for instance, what the utility due to hospitalization, for instance,
Mm.
as a result of 10% increase in pulmonary rehabilitation or 50% increase. Okay, we can have a look at the incremental cost-effective ratios, the cost-benefit analysis, utility analysis. All of these aspects can be measured, which are very, very important, particularly for pharmaceuticals.
So what we're saying is we are running the simulation, looking at various interventions and comparing the cost utility of each intervention against
Yeah.
each other. So if you have limited finances, which ones should we invest in first? Which is going to give us the biggest bang for our buck?
Absolutely, absolutely. So the next part is we've got about 3, 4 interventions. So medicine optimization is another intervention that we're going to be looking at. But there's also community-based intervention, pulmonary rehabilitation intervention. So we can potentially apply or implement each of these interventions, but at what rate? So you might say, look, why don't you go ahead and do 10% of pulmonary rehabilitation, maybe 20% of patients into community services? So that's the kind of the most effective and cost-effective interventions.
Okay, that sounds good. And then next question. So I suppose this might be a bit early, but have Royal Free started to make changes to their systems following the simulation?
Not yet. We're simply um, at the kind of phase of testing all of these interventions. So
Right.
our next thing would be to go back and present our findings, okay,
Yeah.
and demonstrate the interventions that are not just effective but cost effective as well. So that's the phase we're at now. But we're also as your next question, actually, if you want, I can answer that.
Go for it.
Is because this model tested at a single trust.
Yeah.
And what we're now planning to do is to extend this to a fair number of other hospitals or partner organizations that we can work with. Okay, so there's 4 or 5 other hospitals that we're going to be collaborating, hopefully in the near future. That's University Hospital Birmingham is one of them.
Yeah.
There's Nottingham University Hospital, John Radcliffe at Oxford Hospital. So we'll be testing this with 4 other hospitals so that we can generalize this into, so that it can be applied into any hospital in the country.
It's fantastic. Brilliant. Really good stuff. I would say that, wouldn't I? But I really think so. So, last question then, Eren. Could we do something similar, maybe not in COPD, but in other disease areas or other specialties at Imperial?
Oh, absolutely. I mean, we've done for a wide range of disease areas. So not just COPD, we've done this for cataract, for instance,
Yeah.
services. We've done it for deep vein thrombosis in the past, wound care. So this could potentially be applied to any disease category at any location or a service. And there are ways that one could easily generalize these models so that it's applicable to any trust. So you can switch on and switch off certain aspects of a pathway. The OPD, some hospitals carry out surgical procedures, whereas others. And within the model, we can switch that off and switch it back on, depending on the service that you're working with. So yes, absolutely, it could very easily be replicated to any hospital and any disease area.
Very good.
Because the beauty of simulation is there's no limits. Once you're able to capture this reality with relevant data, it's just endless in terms of what can be done with it.
Erin, I think that ends the conversation. I think it's a fantastic opportunity you've developed there at Royal Free. It's really exciting. And we'll see what happens at Imperial.
Brilliant. Thank you.
Thanks, Erin. I will speak to you soon.